Aloha, I am Mark Alexander, Executive Director of the Hawaiʻi Medical Association. Thank you for joining us for today's Conversations at HMA, a program which features discussions with physicians and other thought leaders in the healthcare arena. For this edition, our topic is the psychiatric workforce and access to behavioral health. This event is sponsored in collaboration with the Hawaii Psychiatric Medical Association and the Hawaii Medical Foundation. Since we are using the Zoom webinar platform, we invite you to submit questions throughout this program by using the Zoom Q&A function. Please type in your questions, comments, suggestions, and ideas throughout, and we will feature as many as time permits. The questions will also be shared with our panelists after the program. It is now my pleasure to introduce the moderator for today's discussion, Dr. Helen K. Nalani Blaisdell-Brennan. Dr. Blaisdell-Brennan is a distinguished fellow of the American Psychiatric Association, an APA mental health equity champion, as well as president-elect of the Honolulu County Medical Society and the psychiatry representative to the Hawaii Medical Association. Please welcome Dr. Blaisdell-Brennan.
Aloha, Mark, and welcome all. First, I'd like to introduce our distinguished panelists for this evening. Dr. Regina James is Deputy Medical Director of the American Psychiatric Association and Vice President of the Division of Diversity and Health Equity. She joins us tonight from Washington, D.C., where it's after 11 p.m. Welcome, Dr. James. Dr. Jacob Lee is a child and adolescent psychiatrist practicing in Hawaiʻi. Jeremy Creekmore, APRN, is past president and legislative chair of the Hawaiʻi Association of Professional Nurses. And Dr. Stephen Kemble is a clinical professor of both medicine and psychiatry at the University of Hawaiʻi John A. Burns School of Medicine. Welcome again and mahalo to the Hawaiʻi Medical Association and to our colleagues across medicine for joining us this evening. Concerns about access to psychiatric care continue to surface nationally and here in Hawaiʻi. As medical doctors, we take these concerns seriously. Tonight, we'll focus on physician-led, evidence-based solutions that are already improving access to care. These include expanding the National Psychiatry Workforce Pipeline, strengthening the psychiatric workforce through collaboration with APRNs, and implementing successful collaborative care models within health systems. Before we begin, I'd like to invite Dr. Elizabeth Ignacio, the Hawaiʻi Medical Association's past president and current public policy chief, to share an overview of the current workforce landscape. Dr. Ignacio?
Always hard to find that mute, unmute button. But aloha, good evening, and thank you, Dr. Blaisdell-Brennan. We just wanted to briefly set the stage for Hawaii healthcare and the strong policy work that is happening at the legislature. I know that Dr. James will be able to share with us what's trending nationally, and I'm excited to hear the comments tonight from our thought leaders. They are all, each one of them, experienced healthcare advocates. Our state is facing significant losses in funding due to direct and indirect effects of federal policies as well as tariffs. And more importantly, there are at least 24,000 Hawaii residents who will rely on ACA subsidies for health insurance that will be negatively impacted. So it may go without saying that OBBB, also known as HR 1, has pushed Hawaii healthcare onto our back foot. And this act was supposed to recalibrate Medicaid to its original intent, with supporters stating that no one will lose services if they comply with work requirements that are about 20 hours per week. But many Hawaii policymakers and healthcare leaders have largely criticized this measure as detrimental to our state. There are Medicaid coverage losses. People in Hawaii will be losing long-term care, dental care, and prescription cost assistance. The ACA premium hikes, we expect to cause premiums to be rising at least 75% for those 25,000 Hawaii residents, basically unaffordable. And we're looking at rural healthcare collapse. The reduction in Medicaid may cripple the rural healthcare system, The Healthcare Association of Hawaii anticipates that every hospital in the state is going to be affected, and there's more potential for increased uncompensated care. So, we're hopeful, we're crossing our fingers that the Hawaii Rural Health Transformation Fund, RHTP, can offset potential hospital and clinic closures. As for behavioral care, according to the Substance Abuse and Mental Health Services Administration, 1 in 5 adults in the US have a clinically significant mental health or substance use disorder. Furthermore, the prevalence and severity of mental health conditions among children and teens has increased sharply. Yet many people fail to receive treatment due in part to shortages, especially here in Hawaii, of our behavioral health care providers. In the past, we had one patient and 2 separate systems, physical health care and mental health care. And the attempts to collaborate with each other, at best, that was good, but at worst, we don't talk to each other at all. And the result has been, unfortunately, that there's often fragmented care. And this is particularly a persistent problem in rural and underserved areas of Hawaii. Hawaii hospitals and healthcare systems are working harder in the last 5 years, definitely, to change that and to create a system of care with multiple entry points for patients with their medical issues, integrating behavioral health care services into every patient's experience when and where patients need them, so that they're being effectively treated as a whole patient, both their physical and their behavioral health care needs. Integrated care is the systematic coordination of physical and behavioral health care in acute care, primary care, emergency care, post-acute care, health homes, community-based services, you name it. So Hawaii is working on it for our patients, and that's why we're all here. I'll turn it over to Dr. James to show what's happening, and thank you again for being here, Dr. James.
Thank you for having me. Okay. So what I'd like to start doing with you this evening is maybe just starting off with a couple of queued up questions to help us with the discussion. I'm experiencing some technical difficulties. Let's start this again. Try this. Okay, here we go. So let's start off with a question. What are some of the current psychiatry workforce concerns? And so I'm going to talk to you about this through the lens of the American Psychiatric Association in terms of sort of the national concerns. So I think what has already been stated before is that basically one of the issues is a supply and demand issue. So the National Center for Workforce has projected about 42,000 psychiatrists shortage by 2036. And so while the need continues to grow, the services are not basically there, and they will be decreasing by about 20% in 2030. And this shortage of psychiatrists in terms of the supply and the demand is everywhere, but is really concentrated, as Dr. Ignacio mentioned, in more rural areas. And you can see on this map that that is exactly the case. So more than half of U.S. counties have no practicing psychiatrists, and in particularly in rural areas. And some of the other barriers to helping our mental health workforce in general, but psychiatric workforce in particular, grow has to do with the limited number of GME residency slots. Also because of lower reimbursement relative to other specialties, administrative burden, prior authorization, insurance network limitations, and burnout and workforce attrition. And I might add that another layer is the fact that we have an aging workforce. So many psychiatrists are over 55. So in the next decade, they will be entering retirement. So all of these factors essentially underscore the need to strengthen the pipeline in mental health in general and in psychiatry specifically, so that we could retain experienced clinicians and hopefully reduce the burnout and administrative burden that they're all experiencing. So another question is, so what efforts are underway to increase GME slots and to strengthen this workforce? So APA is very uniquely positioned to lead a number of these efforts from an advocacy standpoint, as well as from a programmatic standpoint, to strengthen and expand the psychiatric workforce. And so I'm going to talk about just 3 select areas that I think are really important. One has to do with increasing Medicare-funded psych residency slots, and I'm going to specifically talk about the Consolidated Appropriations Act. Another is by expanding loan repayment programs. And again, another piece of legislation that we advocated for had to do with the STAR loan repayment program. And lastly, with how are we working with the growing psychiatry pipeline. And I'm going to talk a little bit about the APA Workforce Development Initiative. So this is just a slide that shows some of the pieces of legislation that APA has really advocated for. This is just in the last 2 years, and these are just a select few that have to do with workforce and loan repayment program and things of that nature. And you can go to psychiatry.org to really look at all of the advocacy work that the organization is doing, or you can sign up for advocacy alerts through APA as well, so that you can keep up with all of what APA is doing to support this effort. So in terms of residency slots, so the Consolidated Appropriations Act in 2021 expanded the Medicare-funded GME slots. So it authorized about 1,000 new residency positions over 5 years, so that's about 200 slots per year. And then in 2023, 200 new positions were authorized, with at least 100 specifically going to psychiatry and addiction medicine. And fortunately, this will take effect this July. And in terms of loan repayment programs, here is the reason why we have such an issue. The AMA reports that 27% of psychiatry medical school graduates have a debt of over $200,000, and that doesn't even include medical school. So one of the programs, again, that APA has advocated for is the STAR loan repayment program. And STAR actually stands for Substance Use Disorder Treatment and Recovery, for those who are not aware. This was reauthorized just last year in 2025 through the Support for Patients and Communities Act. And so through this loan repayment program, students can get up to $250,000 for a 6-year service obligation, mind you. So, and that 6-year service obligation needs to be at an approved facility where physicians can work at substance use disorder treatment and recovery programs that are approved by HRSA. Another approach is through the APA Workforce Development Initiative. And this is an initiative that we have that is currently supported by SAMHSA, Substance Abuse and Mental Health Services Administration. So it's truly a pipeline program. We work with students from high school, undergraduate, medical school, as well as residency. So here is an opportunity where we can have touch points early on when they're thinking about going into psychiatry, and really all the way up until their training, so that they can stay connected and stay in community. And through this program, actually, we offer experiential learning, professional development, participation in our governance structure, as well as networking and community. And this is very important because this program has been around over 50 years, and there are a number of leaders in the APA who have been a part of this SAMHSA program. And that part about networking and community is very strong, and it really is very helpful as one proceeds in one's professional career. And this is another piece of the program that I really like to highlight, because it really underscores the partnership between the fellows and the students and the members and leaders in the APA, and that's our advocate protege program. And that's essentially when our members volunteer their time to serve as advocates for the proteges or the fellows in our program. And so just wanted to highlight and say thank you to the members who donate and volunteer their time to make sure that the students in the program have connection to APA and APA leadership. So the last question is, so how should policymakers approach sustainable workforce planning? And this essentially it's a multi-pronged process. So one is expanding the training pipeline. Again, supporting programs through SAMHSA like the APA Workforce Development Initiative, advocating, of course, for more residency slots, which I've spoken about, supporting loan repayment programs. And of course, second bucket is improving access and efficiency, so supporting telepsychiatry. And I think you heard mentioned earlier, supporting collaborative care model. And I think this is really a comprehensive approach that can grow and sustain a psychiatric workforce. And so with that, I will end and say thank you, mahalo, and hand the virtual mic over.
Unmute. Unmute.
You're muted, Dr. Blaisdell.
Thank you so much, Dr. James. You're welcome to remain with us, or it's late on the East Coast, so we all understand if you need to sign off at some point.
Thank you. Thank you so much for having me.
Next, we'll turn to Dr. Jacob Lee, who practices child and adolescent psychiatry on Oahu. Dr. Lee, from your day-to-day clinical practice, are referral inefficiencies contributing to the perceived psychiatry access problem?
I hear that pretty broadly from most of the patients that I see, especially my intakes. A lot of patients kind of complain it's first challenging for them to recognize that they require mental health assistance. But then once patients do recognize this and try to seek care, they run into tons of bottlenecks in the insurer-run websites being frequently out of date, having challenges with really coarse kind of high-level classifications of doctors, but finding it really challenging to find doctors through their insurer that meet their specific needs. So if they require a special type of psychiatry, it can be really challenging through those kind of official portals to find the right providers. And many patients who I refer to other mental health providers find that they have to wade through a lot of inactive providers on these out-of-date kind of insurer websites. So I think there's a lot of referral inefficiencies that really are stumbling blocks for many of our patients.
Thank you. Well, we have some Queens Medical Center residents who are viewing this webinar, and they just the other day informed me that patients at Queens can see a psychiatrist in a week, but the wait time for a psychologist can be months. How quickly can a new patient get an appointment in your practice?
So for everyone's kind of context, so I work in a small group private practice clinic in town. I personally am able to have some time that is set aside as protected time for new patients. And most of my new patients are able to be seen either the Monday after requesting to see me or one Monday following that. So kind of between 1 to 3 weeks, but almost all patients are seen within 2.5 weeks or less of their referral. Probably about 8 to 10 days is sort of the expectation there.
I think that's a lot faster than many lawmakers think. What would you say would be a way that Hawaii Medical Association and HPMA can help with referral inefficiencies?
I think one thing that would be really helpful is on, say, the insurer, provided site, really having more granularity and advocating for either a requirement or at least a request that the insurers make more specific providers more available. I also think, as we're getting more primary care doctors that are trained in helping provide some kind of elementary mental health services, I think strengthening the pipeline for referral out from these primary care providers when mental health is needed. I hear a lot of these primary care doctors are just kind of Googling and finding our clinic in that way. But I think really strengthening some of the pathways that bring patients from, their primary care providers or from other advanced practice nurses or other people to strengthen that pathway so there's a more easy, natural way for these patients to receive specialized mental health care through a psychiatrist, for instance.
Thank you, Dr. Lee. You're a tremendous resource. And if you don't mind, will you hang on? We have a question and answer period at the end of this hour.
Absolutely, of course. Thank you.
Next, we have Jeremy Creekmore, our APRN colleague. Could you share your perspective? How many APRNs currently practice in the state of Hawaii?
So total APRNs of all specialties is a little over 3,800 actually. When you look at psych specific, we are spread out across the state. So in Kauai, we have 11, Hawaii Island 23, over on Maui, we have 16, and then 94 here on Oahu.
So I personally know that I work closely with APRNs. We often share ideas on how to treat patients. In your opinion, how do APRNs support and strengthen the psychiatric workforce?
I think first and foremost, due to our full prescriptive authority, full practice authority with prescriptive authority, which allows us to bring full care psychiatrically to the patients. And I think something that's very interesting when you look at the APRN perspective from the past, where we were boarded either in adult or child and adolescent. Now the education and the board circumstances across the lifespan. So we really have the ability to come in and deliver high quality care across the lifespan concerning psych.
Now, you're currently at Brain Health Hawaii, is that correct?
I did work with them for a while. I have my own private practice, actually. Yeah. Mm-hmm.
So one of the things Dr. Ignacio and I frequently talk about is how the medical model involves teams. We're trained from the time we're medical students and residents to work in conjunction with our partners who are cardiologists and neurologists to understand when we're outside of our scope of practice and to reach for help. How do APRNs do that? And how does that work in an integrated practice such as the one you were previously in at Brain Health Hawaii?
I can't speak for brain health particularly, but I think collaborative care is first and foremost. It has to happen. I can speak for, my own experiences that it's very, very important to involve primary care, especially so everybody's kind of on the same page with what's going on with the patient. And through those pipelines too, same thing. We need to get patients to specialty care. As we know in psych, there's a lot of things that we'll pick up that they tell us that they may not tell primary care because they feel comfortable. And I think it's so, so important. And I think the APRNs in this state have a very good track record of working collaboratively across the specialties to try to ensure patients get proper care.
Thank you so much, Jeremy. I know that you might have another engagement this evening. You're welcome to hang out because I know people will have questions, but please stay with us as long as you can.
Thank you for having me. And as always, our APRN workforce is ready to serve at any moment.
Fantastic. Okay, now we have Dr. Stephen Kemble, Professor of Medicine and Psychiatry at the University of Hawaii. Dr. Kemble, welcome.
Hi, and aloha to all of you. I am actually recently retired, but I was in practice from 1985 until a couple of years ago. Private practice until 2017, private group practice, and also working in Queen Emma Clinic as a psychiatrist embedded in primary care since 1989 until I retired. And I was a pioneer in Hawaii for implementing the collaborative care model. And let me just describe how it works. One module would be 2 hours of a psychiatrist time a week and a full-time care manager, which in the case of the Queen's program was a social worker, and consulting to primary care practices, or really could be any specialty. We also consulted to neurology, geriatrics, a number of APRNs. Anyone who wanted our expertise could call us. The care manager, the social worker, would then contact the referring practice and the patient by phone, usually within 1 to 2 business days, and get a history from both. And usually we had access to the chart because most people in Hawaii use Epic. And then the social worker would present to the case of the psychiatrist at our weekly interdisciplinary team meeting. And I would go over I get the history from the care manager, go over the chart, and then make recommendations to the primary care practice on how to manage that specific patient. And that includes both pharmacological and psychological advice, strategies for dealing with, personality disorders and things like that, whatever. And then the team would follow up generally by phone as often as needed until the patient was stable and didn't really need our expertise. Care stayed with the primary care practice. They were the prescriber. We would just give them advice, and they didn't have to follow our advice. Sometimes they would decide not to for whatever reason. And then if there are any questions or problems, if that worked out, fine. If it didn't work out, they could call us back in and ask for more help, and we were always available. We signed up about half the independent primary care practices in Hawaii, which includes a lot of the independent ones, plus the Queens affiliated clinics. And we had 3 modules, 3 psychiatrists and 3 care managers. We served a total of about 1,200 referrals who engaged with our services over the course of 7 years that I was working with the model. And it worked really well. The model was designed for mild to moderate disorders such as anxiety and depression, but because of the shortage of psychiatrists, the lack of availability, or the ones that were there wouldn't take Medicaid or things like that, we ended up covering any diagnosis. So we dealt with quite a lot of substance abuse, geriatrics, schizophrenia, bipolar disorder, borderline personality disorder, because we were the only option. There was no other option for direct referrals in most cases. When we did feel that a patient needed direct care, the care managers got to know who was available in the community. Sometimes they could twist the arm of a psychiatrist, especially if the patient had commercial insurance, and get them in, or they could refer them to a psychologist or social worker for psychotherapy in the community. So we functioned as a triage service as well as a consultation service to facilitate getting people to the care that they needed. We did something unique with financing, because there are codes that CMS offers which have to be submitted by the primary care practice, which is then collects from the insurer, a copay from the patient, reimburses the psychiatry team. And none of the insurers in Hawaii were able to get this up and running functionally. And what we did is we went to all the insurers and got them to fund our program directly. So some of them would do it like, you have 7% of our caseload, so you can fund 7% of our budget. That's the easiest way. A lot of the others did it on a case rate basis, where we would keep track of our time and submit it as if we were going to do fee-for-service billing, and they would pay us what they would have paid the primary care practice, but they paid us directly. And it just went into our budget. The professionals were paid with salaries. And we found that by not having to do any kind of billing and collections, because we were paid up front, that we could cover 100% of our costs and make our services available irregardless of the patient's insurance status, even if they were uninsured. As long as the primary care practice had signed up with us and gone through a training session or 2, we would help them in whatever way we could, and follow the patients regardless of their insurance status. Programs on the mainland have generally had trouble covering more than about 80% of their costs with fee-for-service billing. We could comfortably cover 100% of our costs and make our services insurance blind because of the efficiency of not having to deal with the administrative overhead of billing and collections. Our data on outcomes is exemplary. We were averaging about 20 referrals a month from all insurers and all diagnoses. We had an average of 5-point reduction in PHQ-9 depression scores for patients with depression. And about, our statistics were 43% achieved greater than 50% reduction in PHQ-9 scores, and 39% achieved full remission with score of less than 5. Also with anxiety, we had similar results, the average of 4-point drop in the GAD-7 scores, and about 68% achieved remission from their anxiety disorder. We also had substantial reduction in hospital and emergency utilization. Emergency room visits dropped 32% in the first year compared to the year before the patient was referred to us. Inpatient admissions dropped by about 35 to 45%, and readmissions also dropped by 70%. So the insurers were happy with that. There are also some studies looking at the difference between collaborative care results and those with either primary care psychotherapy or primary care treatment of depression in particular. And those studies show that primary care was able to get about 70% of the people they felt needed treatment for depression into treatment with themselves, whereas our engagement rate with collaborative care was 78%. And the primary care practices got to remission in about 23% of the time, and we got to remission in 40% of the time. So clearly we can do, collaborating with primary care, we can do better than primary care can do on their own. There's also a study that looked at co-located care where you have a psychiatrist embedded in a primary care clinic, and the patient is referred to the psychiatrist for direct care with a warm handoff versus collaborative care. And again, collaborative care did better because what happens is when you refer to the psychiatrist directly, about half the time they don't show up for the first appointment. For an outside referral, for an inside referral, maybe it's 40% of the time they don't show up for the first appointment. But because with collaborative care, the continuity is with primary care, they tend to stick with it, and we had a much higher engagement rate. And in this study, again, with co-located care, they got 14% reduction in PHQ-9 scores in the first 12 weeks. Collaborative care got 33% reduction in the first 12 weeks, and our Queens team got 38% reduction in symptoms of depression. So we were doing as well as or better than pretty much any other model out there. The other thing is that this model is adaptable to any specialty or subspecialty referral that doesn't require an imminent procedure. My daughter, who's a cardiologist specializing in adults with congenital heart disease, which is very specialized, and it's also a field where you absolutely need specialized expertise because if you do ordinary things to someone who has abnormal cardiac anatomy, you can kill them. Or certainly result in unavoidable hospitalizations. So my daughter is doing the same model with cardiology, also through Queens, using the same social worker care managers that I used, and finds that it works very well for adults with congenital heart disease as well as for psychiatry. So I really think that this is something that could be expanded, and with our funding model of direct funding and not using fee-for-service billing or capitation for that matter, just direct funding, I think we could go a long way towards solving our physician shortage, workforce shortage problem. Thank you.
Thank you. Dr. Ignacio, do you have a question?
I'm just, as always, when I hear Dr. Kemble speak, I'm just amazed. And thank you so much for being here. I'm learning more about these behavioral health collaborative codes, and I'm curious of the different approaches that may have been successful in other states. You may or may not be able to comment on in terms of scaling the system for those co-located areas, like, the other sites where patients may enter the system in oncology or cardiology, endocrinology, OBGYN. Have you heard of that?
The only example that I know of is my daughter doing this for adults with congenital heart disease. And part of the problem is that the CMS procedure codes for collaborative care are specific to psychiatry. There are no codes for any other specialty. So unless you can work out direct funding, which Queens is working on, there isn't an easy way to do it for other specialties. But this direct funding model could be applied. You just got to get everybody on board. And the statistics for both psychiatry and for congenital heart disease are very impressive. This model really works. And once the insurers see that and how many hospitalizations it can prevent, they usually are willing to come on board and fund it.
So I have a follow-up question. What would it take to replicate the collaborative care model in a specific rural area? Let's say island of Hawaii or island of Maui or island of Kauai.
Okay, the Queens program operates on all islands. So as long as the primary care practice contacts us, goes through a training session on how the model works, and has a business associate agreement to satisfy HIPAA requirements, it can happen remotely. We're generally operating by telephone anyway on any island, and we are already operating on all the islands.
So am I hearing you correctly that you could effectively use collaborative care to serve federally qualified health centers on any island?
Yes, any practice that signs a HIPAA compliant agreement with us, we can serve.
Okay, Mark, do you have any questions that are coming from the audience?
Yes, we have a number coming in Q&A. One of them, Dr. Kim, what are barriers, legislative and otherwise, that you see that prevent widespread adoption of collaborative care in the state?
I would say the biggest barrier is the difficulty dealing with the fee-for-service billing codes, because it's a burden for the primary care practice. It's a burden for the patient who's getting charged for a doctor they don't see directly. And it's a burden for the collaborative care team. But our funding model avoids all those problems. So that really shouldn't be a barrier, but a lot of practices don't know that until they check us out. We had a lot of primary care practices who were skeptical of our model because they didn't want to deal with psychiatric problems. They wanted someone to refer them to. They couldn't find anybody. But when they tried us because they didn't have an alternative and realized that we actually took the burden off of them, because the care manager would follow with the patient by phone, make sure they followed through. They were getting expert advice whenever they needed it, so that relieved them of the uncertainty of dealing with a problem they weren't comfortable with. And after a few referrals, they started really loving the model, and we had very positive feedback once we engaged.
One question and comment from a neighbor island participant, Dr. Walco, I believe. This conference belies the reality, at least in East Hawaii, of the impossibility of getting prompt psych care for kids and teens. A next week appointment never seems to occur in Hilo, a more 3-day wait in ER. Please speak to this issue on the outer islands.
The collaborative care model is available because if the primary care practice has signed up with us, they call us, we get a hold of them by phone. In one or two business days, we'll get a hold of them by phone, contact the patient, get a history, and then tell the primary care practice what to do. They don't need to be referred to a psychiatrist to implement the model. If they have something really complicated and really need a psychiatrist, that's a real problem then, because there's so little available on the outer islands. Our care managers do get to know who is available, and they will do their best to arrange referrals when necessary. But it is difficult, especially if the patient has Medicaid.
And then a final question, some of which you touched on. Dr. Kemble, great program. How widespread is this collaborative care model, I presume? Does it have problems being brought to scale and or accepted by insurers, providers, and patients?
There are some skepticism up front when people are unfamiliar with the model, but generally once they've started using it, it works well for the primary care practice, it works well for the psychiatrist, and it works well for the patient. So a lot of it is just sort of getting people familiar with the model, having them try it out and realize how it works. And so there is some upfront barrier because it's a new thing, and it isn't what what the primary care practice thought they were looking for. They wanted a referral, but it actually works very well for all parties in most cases. There are always some exceptions, but even with direct referral to a psychiatrist, there's patients that don't click, that don't show up after the first appointment. There's always failures, but I think the failure rates with collaborative care are no higher than they are with direct referral and probably a little lower.
Is this program pretty widespread then?
There are programs for collaborative care scattered all over the mainland. It was originally developed at University of Washington in Seattle, but we're the only ones that are doing the direct funding. Everyone else is using the CMS procedure codes.
That's it for the Q&A right now,
Yeah.
I think.
So Dr. Kemble, I have a question. Has the state of Hawaii or have any outer island federally qualified health centers reached out to you to engage with your collaborative care model?
I'm not aware of federally qualified health centers reaching out to us because a lot of them have hired in-house psychiatrists. So not all of them, but some of them have hired in-house psychiatrists. But there's really no reason that federally qualified health centers that don't have their own psychiatrists couldn't use our model. It would work very well. Yes.
Aloha, Lisa Ignacio again. I wanted to ask, Dr. Lee, as well as Dr. Kemble, when it comes to going back to that Hilo question, do you see a difference in use of collaborative care in pediatrics, geriatrics, some of our more vulnerable populations of patients, or do you find that their needs are met in different ways? What are you seeing for the neighbor islands in terms of pediatric, for example, pediatric behavioral health care?
And regarding the collaborative model, maybe Dr. Kemble can respond to that portion. Then I have another element about access to care for the outer islands after.
Well, we had 3 psychiatrists at the point when I retired, which was 2 years ago. One of whom was a child psychiatrist, and one was a geriatric psychiatrist. And I also did geriatrics, but I didn't do children. But we did have a child psychiatrist. So
Great.
those needs could be met from the team that we had. We did a lot of geriatric consults. Aloha Care in particular gave us a grant to help with nursing home consults using the collaborative care model. So that meant we got a whole lot of geriatric referrals, and our team became very experienced with that.
That's wonderful.
I have the great privilege of working with a variety of patients from Lanai, Molokai, and from rural part of Hawaiʻi Island. And one element that's really prevalent in my work as a child psychiatrist is prescribing medications that are controlled substances, which previously required inpatient or in-person visits in order to obtain some of these medications. Due to the COVID pandemic, there was a temporary waiver that allowed for these patients to receive these teleservices, which has greatly expanded the outer islands' ability to receive quality healthcare from their providers. And, in my view, are still able to receive, MD tier or, highest quality care. There is occasionally a discussion about trying to roll back this provision, which would seriously impair the ability of the outer island patients to receive kind of standards of care, care as is advocated by all the major American medical associations. And I think that's another factor that, fortunately right now, these patients are able to receive this care without the tremendous burden of coming to Oahu to see me for 15 minutes, for instance, but is another access to care that is essentially a legislative issue.
I agree.
Dr. Kemble, would you be able to provide contact information so that any of our partners on Hawaii Island or Maui Island or Kauai Island could reach out to you either in the chat, or maybe they could reach out to HMA and we could provide contact information so that they could align with you and make use of your collaborative care services?
It would be through Queen's Clinically Integrated Physician Network, QCIPN, and I'll dig up the phone number and put that in the chat.
I wanted to ask Jeremy Creekmore, you spoke about having broad training across the lifespan, including children. What would you say is the frequency of attention deficit among the children and adolescents that you see as an APRN?
A lot of the kids that are sent to me have had testing even. So I think that the ratio may be a little skewed. But I do think what's important in any circumstance when you're dealing with something like that is to look at other comorbidities, especially anxiety and depression. I think that all too often we forget that those are core features of both of those. And, when you look coming into the pandemic, when everything was in disarray, and something I thought about at one point was a lot of these kids didn't even see a classroom until they were in first or second grade. They only saw it through movies or TV or online. But, I certainly think that we have to take into consideration the whole with the kids and not become kind of tunnel visioned, if that makes sense. Because a lot of the times I've found that there's also that underlying thing that needs to be addressed before anything else. Because we won't really know, right, until we tamper down those other separate pathophysiologies.
Dr. Creekmore or Dr. Kemble or Dr. Lee, can any of you discuss complicated patients that you've seen where along the lines of what Dr. Creekmore has just discussed, where it was important to rule out medical diagnoses before prescribing medication?
I refer a lot of patients to the medical team at Kapiolani Medical Center for Women and Children. A lot of patients who, for instance, have diagnoses of, say, autism and intellectual disability, where it's really necessary to rule out a wide variety of genetic syndromes or mutations that can really inform a lot of their cardiovascular risk or kind of some of these other factors. Sometimes that'll also require brain imaging or laboratory testing in order to rule that out. And that really absolutely requires a collaborative, approach. An outpatient clinic, it's simply impossible to directly do some of those testing or to do some of the high-level genetic counseling that's offered, at places like Kapiolani Medical Center.
I'd second that absolutely along the same lines. And pharmacogenetic testing too, which plays such a critical role and stretches well beyond the realm of psych. And so I would have to second what Dr. Lee said and throw in some pharmacogenetic testing in there too, which is really important. And when cases don't really seem complicated, can all of a sudden become complicated just based off of that as well.
Dr. Kemble, seeing a large number of geriatric patients, how did you thread the needle when there was a condition for which antipsychotics might be indicated, but for which there's a black box warning for people over a certain age?
Well, we try to use antipsychotics as judiciously as we can, but sometimes it's a situation of if you don't do something, the patient's going to be evicted from the nursing home. And sometimes you have to try. We tried go low dose, go slow, and even the best results with antipsychotics are less than 50% with any given drug. So more often than not, they'll get side effects rather than benefits. But once in a while, it'll really work. So you're trying cautiously a series of things, trying to start with the least harmful and work your way up until you get something that helps. We also really tried to talk to the nursing home staff about how they interact with the patient, and if any of them noticed things that worked for them with some staff, maybe that other staff could learn from. So we look for psychosocial approaches as well as pharmacological approaches, and tried to exploit anything we could find that seemed to be helpful with that particular patient.
Jeremy or Dr. Lee, have either of you experienced, or can either of you recall a time when you had a real psychiatric or medical emergency? And how did your medical training direct and inform how quickly you responded and what you did next for the patient?
I'll go on this one. Commonly used medications for people requiring mood stabilizers would be medicines like Lamictal, which is generally thought to be a very safe medication. But in Hawaii in particular, it can be extra challenging to use as people with East Asian ancestry are extra likely to experience rare but very severe medical emergency type side effects. It's the kind of thing you could potentially go your entire career without running into, but in Hawaii might be particularly more likely. I had a patient who had recently started the Lamictal mood stabilizer and had a quickly spreading rash, which many people would give kind of generic rash counseling here of, oh, what did you change your lotion? And then maybe we just keep our eye on it and I see it in 2 weeks or something. But, recognizing from my medical training that Stephen Johnson's rash can be life-threatening in an urgent manner, called the patient, provided same-day counseling for the patient, was able to, give them advice. And, fortunately, nothing dangerous happened to this patient, but we know, unfortunately, from clinical experience that Stephen Johnson's rash can be lethal and kill people on an immediate time scale, which is something we certainly don't expect for rash and something that you wouldn't necessarily think of for this medication that otherwise has such a high safety profile. So it's something that, I'm really thankful for my medical training and, in that case, the extensive psychopharmacological education that we'd received, as part of psychiatry residency.
Definitely important to be able to recognize those symptoms. I've had a couple of times that what I even suspected was some epidermal necrolysis type situations, and it's very critical to recognize that and get that taken care of very quickly. And I think even when you get a patient in that's suicidal, being able to, number one, it's rapport is your big thing, rapport and trust, and being able to talk them through the process and help them the best way that I can.
I'm glad you raised that topic because there's been some question about whether medications are the most direct way to serve a suicidal patient. In your experience, Dr. Kemble, Dr. Creekmore, and Dr. Lee, what is the best way to address a suicidal patient? Because that's a concern that's on the minds of many in Hawaii today.
I agree with what Jeremy just said, that it's the relationship that is your best defense against suicide. If you were to just give a patient a prescription and say, take this, you'll feel better, there's a high risk they would overdose. One of the highest risks for overdosing is a patient who is admitted to the hospital because they are suicidal and then discharged prematurely before they were better, and then they go home and attempt suicide. But I find that if you're able to make a connection with the patient, if you're able to get them to tell you what brought them to considering suicide, what the backstory is, and reach a point where they feel that you understand why they feel the way that they do, the chances they're going to try to kill themselves go way down right there. So that's what I'm looking for. And I consider that more valuable than any medication.
Agreed. Thank you. Jeremy?
Get that to work. Yeah, I think that it's important not to be too tunnel visioned, into medication at crisis point. A lot of the times at that point, number one, they're irrational, even if they don't show it. And it's our job to help them and coach and lead them in what's going on. And we have to remember that post-discharge, right? Post-discharge, a lot of the times they are started on things, fortunately, and stabilized. But some of those medications, as we know, particularly antidepressants, there's that window we've got to kind of keep a close eye on. And hey, how you doing? How's things going? Anything I can help you with? And just continuing to let them know that we wouldn't do anything to them to cause them any stress or harm. You know, that everything we want to do is to make sure that we care for them and that we can see them continue to grow and recover. And sometimes when all hope is lost, helping them realize that recovery is based on them, that we see similar experiences across people's recovery, but we want it to be unique.
Jacob, do you want to respond? And then we have one more question and we can look at wrapping up.
Yeah, regarding the point about non-medication options for reducing suicide, I'd just like to maybe remind or to inform, many studies show that a crisis safety plan is one of the most effective ways of reducing suicide for these people. What helps you have better outcomes in a fire? A plan. What helps you have better outcomes in a tsunami? A plan. Having a predetermined plan conversation with family is a huge advantage, or with patients is a huge advantage in these situations. Having a pre-thought out plan of what if your symptoms escalate in this or this way. The other thing is in Hawaii, we have the advantage, not only as America rolled out the 988, kind of our 911 calls firefighter police, and 988 gets you crisis intervention trained helpers, but also we have the Hawaii Cares extension there where in some circumstances it's possible to send crisis intervention trained social workers to or other providers to on site to people to help provide care, or in a phone or texting conversation to provide what can be life-saving advice for these people. So a great resource, and one I'm thankful that not only has America rolled out, but Hawaii has really reinforced with the Hawaii Cares line.
Absolutely. The Prevent Hawaii Suicide Task Force emphasizes that the main tools to prevent suicide are connections, care, empathy, reducing access to medications that they might overdose on, reducing access to other lethal means with respect to firearms. So I think we're all on the same page here. Mark, did we have a final question before we say aloha?
Yes. One comment, thank you for asking the suicide prevention question and addressing it. A last question, would psychologists have sufficient training to diagnose these side effects?
I'll let Dr. Kemble answer that because he's the most senior of all of us here.
Well, I think that psychologists do get some training on lists of side effects, but you have to have run into them in clinical practice, a number of times before you really get the kind of judgment you need as to what could be a side effect, what is probably something benign. And it takes a lot of patient exposure to reach that point. Psychiatrists have somewhere around 10 times more.
15,000 clinical hours, yeah.
Yeah, 10 times more, supervised clinical experience than even the most advanced psychologist prescription program. So I just don't think it's comparable. I will say that when I entered psychiatry, they went through a period when they did not require a medical internship. You can go straight from medical school to psychiatry, and they had to backtrack that after a couple of years because the residents coming into the programs did not feel comfortable handling medical problems, side effects, emergencies, things like that, and they had to reinstate the internship. Myself, I did a full internal medicine residency before I went into psychiatry, so I was way ahead of them, and just my comfort in dealing with emergent situations. But I do think it takes more than just a few courses on pharmacology and side effects. You really need a lot of supervised clinical experience.
Okay, any other additions before we say mahalo? All right, we want to thank everyone for joining us tonight. Tonight's discussion highlights several important points. First, as Dr. James pointed out, the American Psychiatric Association and the U.S. Congress are already expanding the national psychiatry workforce pipeline through increased graduate medical education positions. Second, APRNs across the state have significantly expanded the psychiatric workforce and strengthened access to care. And third, collaborative physician-led models easily and safely extend psychiatric expertise and improve patient access to patients on all islands with all different kinds of insurance. Mahalo so much for joining us. Improving access requires strengthening systems, not fragmenting standards. Have a wonderful evening, and everybody stay safe as the rains come down.